Thank you, Dr. Rogers, and thank you all for being a part of this. Great experience for me. I've been here many times over the decades and have admired the incredible work done at this institute, in this medical center, developed many good friends here, and so it's an enormous pleasure for me to be here today and to share with you some of the interesting developments in carotid stenting that have occurred. I'll tell you a little bit about all of that as we move through this presentation. First, my conflicts of interest. I am a director of Inspire MD. It's a public company and an equity holder, and similarly an equity holder in another medical device company, Contago Medical. So we're going to talk about this procedure and how it came about and what it can do in improving patient care. And the mission for me over the last 45 years has been trying to improve patient care by minimizing complications from invasive approaches to treating disease, just as I learned from Andreas Grunzig, who did the first balloon angioplasty in the heart. And Andreas Grunzig, amazing man, he said, why do we run the saw down the sternum when we need to treat 1 millimeter of blockage in that artery? If we can go in and take care of it with minimally invasive therapy with a balloon. So my approach to everything I've done over the last 45 years has been to try and improve patient care that way. What we have with carotid stenting is a procedure that really is a very reliable procedure for those of us who can make good decisions about patient selection and technique. But that's true for all medical procedures. Procedure time is about 30 minutes, fluoro time 10 minutes. I've done about 3,000 carotid procedures or supervised them in my group over the last 25 years. And you can do these procedures with 5 cc's of contrast, you just 1 or 2 little puffs. But on average, it's 25 cc's is about right. There's no general anesthesia, no sedation. And as I'll point out, it's a procedure where there's no surgery, so we can no general anesthesia, and we can send the patients home the same day. And in fact, we've published data on this. Typical patient admitted 7 a.m. and sent at 9 and discharged at 3. I've discharged them even earlier. That's what we're talking about today, and I want to talk about how we've developed this and how we've improved the outcomes and what we're doing as we move forward. Let's just revise a little bit about what we know about carotid disease and carotid stenosis, and this is important when it comes to patient selection. We know that symptomatic patients with TIAs or recent strokes are at risk of recurrent strokes without revascularization. There's no question, no debate, whether it's endarterectomy or whether it is stenting, then that's very important because the stroke rate is about 13% a year. For asymptomatic patients, it's a more interesting question. I'll talk about this. Depending on the degree of severity, the risk of stroke may be as low as 1% per year if you have only a 50% lesion, or it may be as high as 4% per year if you have a high-grade 80 to 90% lesion. So that's important to keep in mind as we work through this discussion. Now, this is not a carotid. Most of you will recognize this is the right coronary artery, but it relates to, it relates to how I got into carotid stenting, because this is treatment of myocardial infarction, and this happens to be the first publication of anyone using a stent in this right coronary artery, which they're very difficult to keep open with all the clotty, damaged tissue. And we place a stent, And this is the basis for all of our STEMI interaction at this time. Now, this is a publication from UAB with my fellows. Come on, guys, we need you to put these case reports and research together. But this is published back in 1991. Why is that important? Because in 1994, I'm at the University of Alabama, and this guy, Jay Yadav, he's a board-certified neurologist. He came in, he called me on the phone first. He said, come and see you. He said, we're just not doing anything with strokes, and you guys now are doing amazing things with stopping heart attacks and myocardial infarctions. So I want to do the same thing in the brain, and I don't know how to do it. And I want to come and train with you, and we can do this together. I said, whoa, okay. So if you want to train, the first thing is you have to get into the cardiology program, the interventional cardiology program. I'll teach you all the interventional techniques, because at that point I was doing a lot of peripheral work as well. I was lucky to have this guy, Shriyam Iyer, who became my lifelong partner as we moved around the country. That is me with a head of dark hair back there. This was what medical innovation and clinical work can do to you over 30 years. And this guy is a neuroradiologist, was a neurosurgeon before that, and it speaks to the multidisciplinary team. So I had neurologists, I had this guy who was a very, very good peripheral interventionist, and myself, and a neurointerventionalist who was able to bring this team together for us to approach carotid stenting. This is the 1994, the very first angioplasty and stent. People had done some anecdotal reports of putting a stent somewhere in the great vessels, but no one had submitted to their IRB a protocol for an intentional study of whether this could become, in fact, a viable technique. We did so, and this was a Palmaz stent placed in this 10 millimeter Palmaz stent in this internal carotid artery. Now, we did about 20, 30 cases with the Palmaz stent, and then we followed our patients up very carefully. They started to come back with the stent crushed in this peripheral artery. There were no complications with it, but clearly not ideal. We needed a self-expanding stent, and that's where the contemporary stenting began back in 1994, with actually the use of a tracheobronchial wall stent. If you can believe, that's what we use for this massive, long O-35 delivery system. No embolic protection devices. We had to figure this out, and we did. But there was some incredible resistance. The vascular surgeons had been doing very effective and very safe endarterectomy for about 30 years. Said, wow, how can this new, less invasive technique be as safe and effective as, and validated, by the way, as the time-tested carotid endarterectomy technique? As we develop every new technique, it's a fair question. Same as angioplasty, stenting, coronary stenting, anything we do, we need to be prepared to work to validate what we're doing with rigorous prospective, randomized if possible, not always possible, but prospective rigorous studies where all the endpoints are measured very, very carefully. So we set about doing that. In fact, we entered into the CREST-1 study. 1998, I began working with Bob Hobson, a vascular surgeon, Tom Brott, to put together that study, which took us 10 years. We finished that in 2010. But the results of all the studies we have done represents unparalleled level 1 scientific evidence that the technique that we developed, with the improvements along the way that I'll speak about next, has a place alongside endarterectomy as a very, very effective technique for preventing stroke in patients with high-grade carotid disease, both symptomatic and, as we'll speak about in some more detail, asymptomatic patients. There are many more trials, but all of them showed consistently that on a composite endpoint of complications, which include perioperative myocardial infarction, stroke, and death, there was no difference. However, even though we came out with the first of this data some 10 years ago, we were prevented from getting any reimbursement for this technique because our vascular surgical loving colleagues stepped in politically and prevented this until 3 months ago, when we regrouped and submitted even more data to CMS, and now we have full reimbursement. But that was a 25-year effort on my part and our group of carotid stenters to get this work done. The clinical trials have all shown that the stroke prevention benefits from a carotid stent are equivalent to endarterectomy in symptomatic and asymptomatic patients. There is a little, and the composite endpoints of myocardial infarction, death, and stroke, periprocedurally up to 30 days, were exactly equivalent. However, there were more myocardial infarctions with surgery, patients having general anesthesia, and there was a delta of about 1 or 2% of more minor strokes in those having stenting. Now, this is back now 15 years ago. However, there was a lot of work done on this CREST-2 prospective randomized trials. The one thing that emerged when you looked at the total body of data was that if you look at death, myocardial infarction, major minor strokes, and cranial nerve injury, and you compared that to endarterectomy and stenting, even with the old technology we used 15 years ago, patients, the delta was 3.6% in this prospective randomized trial. In other words, the endarterectomy patients, if you took all of the things that we're not taking actually reoperation or bleeding or hematomas in the neck or anywhere else, but the data was in favor of stenting back then. And it's even better today, as I will show you, because we have removed the risk of minor stroke that was associated with the stent procedure. Now, you would say, if there are any vascular surgeons here, if there are, please speak up. The vascular surgeons have said repeatedly, cranial nerve palsies aren't important, so we can't count those. However, now that vascular surgeons are doing transcarotid work and they're not having any cranial nerve palsies, so they're replacing endarterectomy with transcarotid stenting, all of a sudden the lack of cranial nerve palsy is becoming even more important to them. So I'll stick by my guns here and maintain that even back in 2000, 2010, stenting was a safer, less invasive procedure. And it's mirrored in the SF-36 scores, looking at physical and mental scales of disability. And if you look at CAS or stenting in the red, endarterectomy in the blue, well, very consistently, as you might expect, the patients felt better and did better and were more active after stenting as opposed to endarterectomy. So now we've been going at this for 30 years. So what has this experience taught us? And where are we today as we move forward more aggressively to treat bifurcation carotid stenosis with stenting now that we have full reimbursement? The first message here is that patient and vessel lesion selection is very important. Severe calcification and tortuosity and bad aortic arches and disease associated with elderly vasculopathic patients are not low-risk candidates or good candidates for transfemoral stenting. Some symptomatic patients who are high risk for surgery should still be treated. This represents these exclusions, like this tortuous carotid or heavily calcified arch and bad disease. They represent about 10, 15% of the patients we see, increasing as the patient ages. Stenting is not for elderly patients necessarily. If the 80-year-old has a nice juicy lesion like this, a high-grade stenosis, then that patient is eligible. Operator experience, as I'll show you with some data in a minute, is really important. But carotid stenting, if you select the patients carefully and have been trained, is a very easy procedure, much easier than complex coronary or aortic interventions. Dr. Fraser will affirm that. It's actually, you can have 6 cases lined up in one lab in the day, carotid cases, you can be done by 4:30. The cath lab send them home. You can't always do that with coronary disease. It's a very quick and safe and reliable and predictable procedure. What else has happened? Well, we've developed much better embolic protection and stent technology, which I've been a part of and which I'll explain. And all of this has reduced brain embolization that we saw back when we began this technique. So given these factors of patient selection, operator technique, and technology, where do we stand? So this is a publication from just 2 years ago from the CREST-2 now. The CREST-2 is the study where I'll talk about. We're comparing revascularization to best optimal medical therapy in asymptomatic patients. But we looked at the registry that we had kept of all the operators we credentialed to come into the CREST-2 study. It was a large group, over 2,100 patients. And what did we find? All of these guys, like the operators here at Texas Heart, knew what they were doing, knew how to select the patients carefully, and were using contemporary technology, the best stents and filters available, because we insisted that's what we needed for CREST-2. What we ended up with is looking at the asymptomatic population. They all did well. So the symptomatic group has a stroke and death rate of 2.8%, which is fantastic. The asymptomatic is 1.4%. So if we looked at then the CREST-2 eligible patients, so these were not the sick, dead, and dying, right? Because in clinical practice, we tend to treat them all. In a randomized clinical trial, you can't have them dying from other things. And then what we found was that the outcomes, the stroke and death rate at 30 days was less than 1%. This was with generation 1 technology. And I'm going to lead you into second generation, third generation technology that we have in 2004, which is even better. So how do we do this? Well, we did this because we were very particular about the operator skill and the patient selection. This is a large group of operators, 250 throughout the country, and a large group of patients, over 2,100. So these outcomes can be achieved. And they're very, very important set of data. And they can be improved and made more reliable in the real world with some of the technology I'm going to share with you right now. This is a fascinating graph, and it shows back when we started and the complication rates of all the different early technologies and trials. When vascular surgeons are debating me, they keep quoting all these numbers back here, back from 2025 years ago. But the reality is that right now we're working with about 1%, or in the latest trial I'm going to show you, less than 0.5%, 30-day stroke and death rates. This is dramatic improvements, and this is what we strive for. This is what we have to see. This is what we get when we analyze our outcomes carefully. When you fellows get to work and scrutinize all the outcomes from all the things that get done in this institution and go back and think about how you can make those outcomes better, then you improve patient care. And that's what we did in this technique development, resulting now in incredibly good stroke and death rates of less than 1%, maybe less than 0.5%. So what is this technology that we've developed? The first one is occlusion and flow reversal. In other words, when we intervene on this Gromity-Garrotti area here in the bifurcation, we can occlude, we can do it with TCAR, direct rod stick, patients usually under anesthesia. Surgeons love it because they get the stent, and they get the stent with a little operation, which is really good for them. We can also do it percutaneously. And we've had this technology with the MoMA device for a decade or more. That's number one. Number two is the development of micro mesh stents, which I think have made and will make an incredible difference to bring that 0.5% complication rate down and available for all operators. So this is some incredible data, about 3,000 patients, a meta-analysis of first-generation stents, FGS, and second-generation stents, SGS, and a comparison over multiple studies in multiple countries, mainly in Europe, because they've had these micro-mesh stents. And it shows dramatic improvement in stroke outcomes across the board in the real world, and that not all of these micro mesh stents, one of them, none are available in the US yet, but they're not all the same. And the one that was a standout was this Seaguard micro mesh stent, because they're all made a little differently. This one has the micro mesh on the outside of the nitinol and very small pores that can trap all of the plaque and keep it where it needs to be against the vessel wall and not embolizing up to the brain. This is a 700 or more patient study from 20 enrolling centers in Italy called the Iron Guard study. All these were published in excellent peer-reviewed journals, this one in JACC Intervention, showing a stroke rate of 0.5%. This is with the micro mesh stent. You can see the fine mesh under this flexible nitinol regular stent structure. 0.5%. And this is the reason. This is a prospective randomized study looking at a micro mesh stent, comparing it to the sort of stent that we've been using for the last 20 years, and that was used actually in CREST 1 and CREST 2. What you see on the right here is the reduction in MRI DWI defects. The red representing the number of defects, and the size of the defect is shown in red, and this is the first generation stent. And then with the micromesh stent, you can see this dramatic and important reduction in the number and the size of DWI defects. In other words, the micromesh can be used to completely sequester this material that used to break through the stents and cause these micro embolic events and minor strokes. And you can see from the clinical data and the randomized MRI data, mechanistically, why we're seeing such excellent outcomes. This is the US FDA study with a micromesh stent, and basically the overall composite endpoint was 0.95% for a group of 316 patients. About 25% were symptomatic, and these are the way the FDA runs these trials. Patients with a lot of comorbidities, high risk for surgery. The minor stroke rate was only 0.32% overall in this symptomatic, asymptomatic group. If we look at the asymptomatic patients, and this will be important, and what I'm going to say next about the CREST 2 trial. If you look at these asymptomatic patients, 238, they all had greater than 70, 80% lesions. No one's ever seen a well-audited, rigorously controlled, with the clinical events committee, independent, looking at all the cases of 0.42%. So very, very low stroke rates, because this is important. It's important, as I'll show you in a minute. In the big picture out there now, there's a lot of symptomatic disease, but there's much more asymptomatic disease. We see it all in our clinical practices in patients presenting with all the other cardiovascular ailments that we treat. And maybe the best opportunity to prevent stroke with carotid intervention is with a device or any device that has very low risk from the intervention. And then we know that the long-term outcomes, as I showed you on the Kaplan-Meier curves, are really excellent. So the question is, can we prove superiority to best medical therapy in 2004? Because if you talk to our neurology colleagues, any here today? I'm sure there must be a neurologist in the house. No neurologist in the house. But if you speak to your neurologist or your neurology colleagues, they will tell you there's a lot of data that says we don't need to do anything with asymptomatic patients. There's actually a lot of data that says we probably don't need to do anything with mild to moderate disease in asymptomatic patients. And I believe that's true. In 70, 80, 90% patients, the annual stroke rate is as high as I pointed out, 4%. In multiple published studies with contemporary medical therapy, great blood pressure control, control of diabetes, control of obesity, diet intervention, statins or PCSK9 inhibitors, et cetera, And we have thrown all of those to our patients in CREST-2. So what do we do with this 65-year-old asymptomatic diabetic patient that has this high-grade carotid duplex, 489 over 265, an ugly lesion that looks like that? Doc, what are my options? Do I really need to have an intervention, surgery, TCAR, transfemoral stenting? Can I just take medicines? That's what the CREST-2 trial is about. I've worked on this for 10 years. I had a lot more hair when I started. This is a $70 million NHLBI NINDS study, 2 arms, best medical therapy compared to transfemoral stenting plus best medical therapy, or endarterectomy, best medical therapy versus best medical therapy alone. Now, these are 2 different populations because endarterectomy and stenting treat 2 different populations in different ways. So this is a complicated slide, but I wanted to explain. I don't know the results. We won't know the results until for the 4-year outcomes until 2026. But for carotid stenting, it all depends on the peri-procedural risk. So in this thick dotted green line and this red line, we're looking at stent outcomes. And all of the risk is up front. When you come in and see Dr. Krazier or Dr. Strickland, if you can get out of there with less than 1%, and we know it's 1% per year with the stent, you can end up at 4 years with a 2.6% risk of a bad outcome. Now, if it's a 2% risk, and I've already shown you it may be as low as a 0.4% risk, it makes this number look even better, then you still end up at 3.6%. In the CREST-2 trial, interestingly, medical therapy is the experimental arm. Because although there's a lot of chatter about how good our patients do on medical therapy, no one's done a prospective randomized trial. You need rigorous follow-up in a prospective randomized trial to understand this stuff. So we don't know whether the medical therapy arm will be this blue line at 8.4% at 4 years. We don't know if medical therapy is fantastic. We're going to end up with a 1.2% risk of stroke per year, which we think it might be, still 4.8%. So you can see why the new technology is important, because we can come in nominally lower at 4 years in this randomized trial at about 3.6 to 2.6. And if patients are at 4.8% or even 4%, they're going to ask the question, Do I take the chance? Do I sit on an 80% stenosis, get a duplex every 6 months, worry about every little headache and twitch I get because I'm worried that this thing's going to block or thrombose? Or do I just have a one and done with at Texas Heart Institute at half of 1% risk? And I know the New England Journal of Medicine, the Wall Street Journal, and the New York Times are going to say, medical therapy is as good as intervention. If it comes in, say, at 3.6 and 4.8 p equals 0.5. I don't know. I don't know what's going to happen, but we'll find out. I will still bet that many patients with high-grade disease will want the one-and-done approach. They can enjoy a cigar without thinking they're going to have a stroke. If they're having side effects from their blood pressure meds or their diabetes meds, and they have to stop them for a while, they're not going to worry because this is fixed. Well, we shall see. We shall see. Let me move on just with a couple of little clinical anecdotes, because this is the new frontier for carotid stenting. This is a patient who was transferred to us at Brookwood Medical Center from a rural town in Alabama. You get these patients here, I'm sure. Young woman, 3 kids, unconscious. Takes about 6 hours to get to us. We do an angiogram. She's got brainstem infarction with a basilar artery occlusion. We put up a stent retriever. We pull the clot out. She's got brainstem revascularization immediately. The lesion came from this. She was a smoker, of course. Came from this lesion in her right vertebral artery, which we stented on the way out. This young woman wakes up and is giving me the thumbs up as she leaves the lab. This is the most gratifying thing that you can do as a clinician in a case like this. And it does say something about the time we have to intervene in many of these patients, not all of them, but in many. This is another case representing now what is really good standard practice, I'm sure, here and everyone else. There's a middle cerebral, large hemispheric infarct, distal ICA occlusion, stent retriever, clot comes out, this vessel's reopened. This is now common day stuff. This is where the clot came from. This is after we used a embolic micromesh, an anti-embolic micromesh stent. So we're doing a clinical trial now with all the stroke interventions. If they have what we call tandem lesions, clot up here, high-grade lesion down here, which is probably the source of the clot, we stent on the way out. And with the micromesh stent, we don't know how good it is, how much it's going to improve stroke intervention, but we think it will improve it dramatically. Now, finally, I want to just finish up with something which most of you may not know much about, and it'll take me a minute. And that is this important question of cognitive decline associated with carotid artery stenosis. And this is actually an important endpoint in the CREST-2 trial, where we're doing MRI studies and questionnaires on hundreds and hundreds of patients. Those who get revascularized and those who do not. There is a lot of data which supports this concept that a high-grade stenosis, which repeatedly embolizes to the hemisphere, or just ischemia through not enough blood flow, which we can measure now, that this ends up producing a decline in mental capacity. There's just a lot of publications showing a difference between those with carotid stenosis and those with normal carotid control group. Really quite a lot of publications. So we're testing that prospectively in CREST-2. It'll be very important finding. In other words, even if we cannot meaningfully prevent a lot more strokes than medical therapy, we may prevent dementia in people with high-grade disease. Who knows? That's why we do these incredibly difficult, large, multi-center prospective randomized trials, which are what drives our patient care forward. Oops. So let me summarize and conclude. Carotid stenting has evolved into an extremely safe and effective technique for preventing and treating stroke. The level 1 scientific evidence supports its role as a safer and less morbid alternative to endarterectomy. It's fully reimbursed. Careful patient selection, particularly tortuosity and calcification, and not rushing in to stent elderly patients. And that's a patient over 75, maybe 80, depends on the end of the bed test, and you walk in. Patient selection and technique are critical, but they can be easily learned. They really can be. And the ultimate role of stenting or endarterectomy or TCAR in asymptomatic patients awaits the results of the very important CREST-2 trial, which will be available in 2026. Thank you all for your attention, and it's been a great pleasure, and happy to take any questions. Thank you.